everyone. Welcome to our PCP DOH webinar series. So today is July 20, 2020, and it's a Monday. Our topic for today is cardiopulmonary resuscitation or CPR in the time of the pandemic. So for today, this is our program. I will be your moderator for today. I am Greggy Amador Panga. I'm an internist, cardiologist, and a vascular specialist medicine. Okay, so let's place ourselves in the presence of our Lord. Almighty loving Father, we pray for strength, for guidance, for endurance as we face this present pandemic. Keep us safe, our loved ones, and all of those who are afflicted. We pray for our webinar today, our speakers, listeners, our attendees, our audience. May our learning today equip us with the necessary knowledge and wisdom to surpass these uncertain times. This we ask through our Lord. Amen. So this PCP-DOH webinar for today is made possible in partnership and cooperation with the Philippine Heart Association and the Philippine College of Cardiology, most especially with the CPR Council of the Philippine Heart Association. Just this July 17, 2020, we celebrated our 5th National CPR Day. So the theme for this year was Hands-Only CPR in the New Normal. So this is a nationwide mass CPR campaign that is in partnership with DOH, with the Philippine Heart Association, the Philippine Red Cross, the American Heart Association, the Department of Education, as well as the Philippine College of Emergency Medicine. So last July 17, 2020, we did our nationwide mass CPR campaign. So this was in partnership with Galing Everyone, with the pharma company Gets Pharma. The COVID-19 pandemic has not changed the fact that CPR plays a crucial role in improving survival rates for cardiac arrest. Initiating CPR right away, especially in and out of hospital cardiac arrest, can nearly double the chance of survival from cardiac arrest from 7% to 14% based on the American Heart Association data. So the objectives for today's webinar series are as follows: to highlight the importance of CPR in hospital and out of hospital arrest, and to review the protocol of CPR in hospital and out of hospital arrest. Also, we want to briefly review the risk of SARS-CoV transmission during CPR, and to emphasize the modifications in the CPR protocol when dealing with in-hospital arrest among COVID-19 patients and those with unknown COVID-19 status, and to discuss community CPR approach for patients with undetermined COVID-19 status. So for today, we're fortunate enough that we have two distinguished speakers. Our first speaker is Dr. Francis N. Labapi. So he's currently the chair of the PHA Council on CPR. He was a past president of the PHA Central Luzon chapter and an auditor of the Resuscitation Council of Asia. So he is an internist and cardiologist practicing at Heart of Jesus Hospital and San Jose City General Hospital in Nueva Ecija. Our second speaker is Dr. Neil Wayne C. Sales. So he is a member of the PHA Council on CPR, and he was a past CPR Council chair of the PHA Cebu chapter in 2017 to 2018. He's currently a training corps member of Adult Cardio Fellowship Training at Chonghua Hospital, and he's an assistant professor at Cebu Institute of Medicine. So for our house rules for today. First, this webinar is being recorded. For your questions and comments, please type them in the chat box. You may address specific concerns as a private message in the chat box. During the open forum, the moderator will be the one to field the questions to the speakers. Thank you for your cooperation. So to discuss first, our first topic, so out of hospital cardiac arrest resuscitation in time of pandemic, Dr. Francis N. Labapi, and to follow, to discuss in-hospital cardiac arrest resuscitation in time of pandemic, Dr. Neil Wayne C. Sales. Dr. Labapi.
Okay. Okay.
Shall I start?
Yes, sir.
Okay. Okay, so good morning, everyone, fellow colleagues from the PCP and from PHA and all other doctors who are listening right now. So good morning. And first of all, I want to thank the Philippine Culture Physicians for inviting us to impart the knowledge and some new concepts on resuscitation in this time of pandemic. So as you can see, the lectures are divided into two. One is we'll discuss on we'll discuss on we will discuss first on how to give resuscitation or CPR for out of hospital cardiac arrests. So as what Dr. Pangas mentioned, um, sorry. Uh, okay, as what Dr. Pangas mentioned, the objectives for my topic is actually to highlight the importance of CPR in out of hospital cardiac arrest, and to review some protocols of CPR in out of hospital cardiac arrest, and roughly to review the risk of SARS-CoV-2 transmission during CPR, and to discuss some community CPR approach for patients with undetermined COVID-19 status. So first of all, we all know what is CPR, right? And when we talk about CPR, it's actually cardiopulmonary resuscitation. And what we're giving actually are chest compressions to support the heart. That's the cardio part. And we give actually airway and breathing. That's for the pulmonary part. However, due to the latest data on resuscitation, somehow hands-only CPR or just giving chest compressions are really valid interventions. And in terms of outcome and survival, the data show that it's almost the same in terms of just giving hands-only CPR, aside from not just the usual basic life support that we know, giving chest compressions and giving your airway. So I also want to emphasize that we're actually advocating the encourage everyone to use AED if it is available. Now, the AED is a device that actually gives shock. It will commonly correct and terminate some causes of cardiac arrest, which is sudden cardiac arrest. Which some examples of this are those patients who had a sudden cardiac arrest from a ventricular arrhythmia, like a ventricular fibrillation. Technically, if you have an AED, it will actually improve the survival more than 11 times if you use a AED coupled with high quality chest compressions, either the usual BLS and just plain hands only CPR. So I just want to state, and I know you all know this, the chain of survival. The chain of survival before 2010 is just only 4 links, but right now it's already 5 links, and it composed of your early access, meaning early recognition of an arrest, and second is early CPR, and third is your defibrillation, giving your AED, and fourth is the activation of the emergency medical system, that is your rescue groups. And fifth is the advanced life support and patient care, which is already in the hospital setting. Now, what I'll tackle just now, right now, is only on the basic life support part and up to the activation of the emergency medical system. Okay. And I just want to highlight that most often, or oftentimes, or most commonly, we see patients who suddenly drops dead or collapses. These patients are the ones who had a sudden cardiac arrest. Now, one thing is that this sudden cardiac arrest really can happen anytime, anywhere, and to anyone, even children. And 50% of cardiac deaths occur really as sudden cardiac arrest and may strike people even without history of cardiac problems. I just want to state that in terms of cardiac arrest, still the most common cause of sudden cardiac arrest in the Philippines and even worldwide is still due to cardiac diseases or ischemic heart disease. Any other cerebrovascular diseases, these are still the most common causes of your cardiac arrest. Now, when we talk about cardiac arrest or cardiopulmonary arrest, is actually the failure of the heart to pump blood, and there's compromise of your oxygen delivery to the entire body and circulation, leading to loss of function within minutes. I just want to reiterate that if you are not able to give circulation and oxygenation within the first 4 to 7 minutes, actually the problem is your brain can actually have irreversible death. And if it is more than 7 minutes, the chances of the changes or the injury would be irreversible. And if it's beyond 1 to 2 hours, the tissue injury will actually set in, and that's what we call clinical death. So that's why early CPR is actually important. And as in this slide, if you look at data, if a patient comes in with sudden cardiac arrest, especially if patient has ventricular fibrillation, and there's no CPR done. However, there's AED that was applied around 10 minutes, around 0 to 2% survive. If a patient has, for example, a sudden cardiac arrest with ventricular fibrillation, and CPR was administered as early as 2 minutes, and upon arrival of the AED around 10 minutes, it's estimated that it's around 2 to 8% survival. If you if you're able to see a patient in sudden cardiac arrest, and you're able to give early CPR as early as 2 minutes, and AED was applied as less than 8 minutes, chances of survival is actually more than 20%. And if you were able to see a patient as early as 2 minutes in a sudden cardiac arrest giving CPR, early AED less than 4 or 5 minutes, then the chance of survival reaches, and early ACLS because you will bring the patient to the hospital already. Chance of survival actually rises more than 30%. So this data actually would actually emphasize the importance of giving early CPR and AED that will improve survival of patients, because these patients actually we see them unwitnessed, sometimes witnessed, and if there's early intervention, survival actually increases. Now, what is the rationale for early CPR? We see patients out of hospital cardiac arrest. They usually occur at home, and somehow the sad thing is only about a range about a 10 to 40% that were only given bystander CPR. That's a very low number. That's why we really need to increase awareness on the importance of bystander CPR. Meaning bystander CPR meaning people, not healthcare workers, they just outside who saw a patient who had a cardiac arrest, and are willing to help and respond and save a life. Uh, Also, this is based from the PARO study, which is a Pan-Asian Registration Outcome Study, wherein it's a study on all Asian countries, including the Philippines. These are the latest data as of 2015, that defibrillation attempts only done less than 1%, and the survival to discharge rates to hospital discharge only ranges from 0.5 to 8.5%. The actual worldwide data ranges from 3 to 14%. And in Asia is around 0.5 to 8.5%. And survival to good neurologic functions are ranges only around 1.6 to 3%. So this really will tell us the importance of why do we need to have early intervention, early CPR for patients who had a sudden cardiac arrest. Now, when we talk about bystander CPR, only 10% of out-of-cell cardiac arrests are only witnessed by EMS or the rescue groups, and 59% are unwitnessed. So majority still are unwitnessed as out-of-cell cardiac arrest, and only 31% of them are witnessed by bystanders. Hopefully, CPR was administered for these types of patients. This was a study done in Japan around 2012. So roughly, and Japan is actually a country wherein the number of people who are learned on CPR actually is really high. They say it's around 80 to 90% almost all of the people there know how to do CPR. Now, there's better survival in terms of favorable neurological outcome. And as we see, the study done in Japan also, in the past decades, in 2010, the survival was only 7.1%, jumped up to 9.7% around 2013, and in 2005 from a 3.3% to 8.2% in 2012 due to high yield of bystander CPR done in Japan. Now, before I start on giving concepts on the new normal on how to do CPR in this time of pandemic, these are a rough guide for all of us healthcare providers in making sure that when we respond to a call to help someone who is in cardiac arrest. So these are some of the precautions that we should really understand and take note. So we should be very knowledgeable on things that could generate aerosol or anything aerosol generating procedures or interventions. So it would be the first. And syempre, you determine appropriate location for the patient. You perform proper hand hygiene before, after any encounter of patients. You don and doff with using personal protective equipment and clean and disinfect room after clean and disinfect after any interventions. Now, these are some of the procedures that are non-aerosol generating. And we have here some intravenous injections. They are really safe, doing nasopharyngeal swabs, and even drawing blood work. However, these are the things that could really can give are aerosol generating, meaning they can actually increase the transmission of the virus, is by doing endotracheal intubation, doing non-invasive ventilation, and actually CPR. So this is the reason why we actually want to reiterate that doing CPR actually is an aerosol generating procedure, and we should exercise proper precaution in helping or giving CPR resuscitation to all people in cardiac arrest. So these are in terms of COVID-19. These are some data in terms of COVID-19 related to CPR. This was based on a study done in circulation by Edelson. They noted that the most common cause of cardiac arrest in COVID-19 patients are still due to distributive or cardiogenic shock. Second is due to hypoxia. And third, although this is still controversial, the use of QT prolonging drugs such as your azithromycin and hydroxychloroquine. That's why the latest data now is they actually refrain from using too much of this hydroxychloroquine. Now, in terms of cardiac arrest in patients with COVID-19, it is really associated with very poor outcomes. Like a study done in Wuhan, China, this March 2020, they noted only a small percentage of going into return of spontaneous circulation after CPR. It's only 13%, and only 2.9% were alive at 30 days. One study has a higher numbers in Beijing, China. There was reported a return of spontaneous circulation with CPR at 35.5%. Also, in terms of out-of-hospital cardiac arrest and administration of a bystander CPR. This was data culled from the US from January to April 2020. And they noted that COVID-19 was diagnosed in less than 10% of out-of-hospital cardiac arrest. So really a small number of all the cardiac arrests that they saw, only less than 10% were diagnosed with COVID-19. And only 15 deaths per 100,000 population. And the risk of transmission to bystanders performing hands-only CPR, even without PPE, is actually only 10%. So it's really small. However, we don't know. We just still need to protect ourselves. So we need to put our protective equipment before we do CPR. Approximately one rescuer might die in a 10,000 bystander CPR events. So really small. And bystander CPR saves more than 300 additional lives among 10,000 patients with out-of-hospital cardiac arrest. So it just says that we don't stop doing CPR We just need to protect ourselves. So this is the data that this study releases. Now, the guidelines would tell us the Philippine Heart Association actually released its own interim guidelines on out of hospital cardiac arrest and in-hospital cardiac arrest. And as you can see, and I know you already know this, the yellow boxes are the ones that were the changes that will be introduced in the usual basic life support guidelines. You have to remember that there were no changes in the usual application of resuscitation into patient cardiac arrest as what we all know. So the only changes were actually some changes on the safety of all healthcare providers and rescuers and the prevention, spread, and contamination of to infection during resuscitation. So no changes were done regarding the usual way that we give basic life support for resuscitation. It's just that the changes were only all about rescuers' safety. So even if you look at all the interim guidelines from all other councils in resuscitation, like your American Heart Association, and even ILCOR, you have your UK Resuscitation Council, you have your European Resuscitation Council, Australian, Brazilian, Spanish, all of them would actually point to four basic key changes in the guidelines. The key changes only would center on rescuer safety. Second, on proper airway management and some critical care recommendations for patients who are with COVID-19. Some ethical concerns, especially on patients who with with futile conditions, and some says that you don't do CPR for patients in very severe conditions. But this is something that needs to be discussed in another forum for ethical concerns. And lastly, they recommend continuous and sustained education and training still, even in this time of pandemic, for us to be aware on how to respond, even with some precautions, even with the restrictions. We should still know how to save a life and how to sustain education and training, especially for our healthcare workers. Now, I will now go on to the usual changes in terms of your out of hospital cardiac arrest and how do we go about with saving a life in an out of hospital setting. So, as based from the guidelines, you only see patients or probably who are in cardiac arrest if you see a patient who suddenly collapse, seems to be unconscious, probably not moving, only on visual assessment. So you don't touch the patient actually. You only look at a certain distance and just call his name or her name and call his attention. If he's not moving, is not probably breathing, that's the time you consider probably this patient is in cardiac arrest. So almost simultaneously, you should be you should be actually thinking of protecting yourself if you want to help a patient. If you don't have the equipment to protect yourself, don't intervene in any patient who is probably in cardiac arrest. And at the same time, you check the scene if it is safe before you attempt any resuscitation effort in this case. So I just want to reiterate that when we talk about protective equipment, ideally, if it is available, you put on a full PPE. So when you talk about full PPE, we all know this, is an N95, goggles, face shield, gown, double gloves, hair cap, booties, if it's available. If it's not available, then the minimum requirement actually is you just cover your mouth with a surgical face mask or an N95 if you have, and just cover the victim's mouth with a surgical face mask or cloth, and then just proceed with hands only CPR. So that would be the preparation that you would really do before you attempt resuscitation in out of hospital setting. So once you're done, once you have this, you're protected, you have the gear, the minimum requirement of a face mask, even gloves. You check for responsiveness by calling his attention. Just you don't touch the patient, just call his attention. Just look for signs of breathing. And if it's unresponsive, you call for help. Now, when we talk about calling for help, you should alert the EMT or code team of possible COVID-19 infection. Why? Why is this important? Because for the EMS group or the rescue group to be prepared when they arrive on site and continue the recitation after you've delivered your intervention. So this is very important because sometimes communication really bogs down in this part, and really recommend dispatcher assisted CPR. And for some areas in Manila, they're actually doing it already through the efforts of the Philippine College of Emergency Medicine. Now, I want to reiterate that we don't need to check for pulse and breathing. No need to look, listen, and feel if there's a possible COVID-19 infection. You just cover the patient's mouth with N95, surgical mask, and just proceed with hands-only CPR and not do mouth-to-mouth resuscitation, just do hands-only CPR. So, as I've said earlier, in case the patient has pulse and not breathing, he's not breathing but has pulse, so patient is in respiratory arrest. So you may provide rescue breaths, provided if you have the adequate equipment. In case you have a bag mask device, that is like an ambu bag mask device. You only use this if you have filter, and if you will be ensured that you have a tight seal on it, and there should be two rescuers involved. You cannot do this if you're just a single rescuer. You need two rescuers. But if you don't have this equipment, don't do rescue breaths. Just still monitor the patient, and eventually all patients who are in with respiratory arrest eventually is a pre-arrest event. Eventually they can go into cardiac arrest, and eventually CPR may be done. In terms of considering early advanced airway, will be the part wherein the rescue groups will come in, or the paramedics, if they have the equipment. Early advanced airway is recommended, especially the use of supraglottic airways for these cases. Don't give rescue breaths because they really can increase the transmission of the virus. Now, as usual, after everything is done, an AED arrives, you look the patient at AED, you just follow the normal, you just follow the normal algorithm. If it is shockable, the machine will tell you to give shock, and after giving the shock, you just administer CPR with all the safety precautions. And the most challenging part here is after saving a patient is the doffing part. So you should be very cautious when you remove your PPE. All of the safety instructions there. You throw away all disposable equipment properly. You disinfect, sterilize, and all the waste should be double bagged and you should dispose it properly in these cases. So I just stated the usual flow for autovagal cardiac arrest. And with that, uh, the importance of people knowing this, because we need to increase bystander CPR rates. That's why, as what Dr. Panga said earlier, we already have a CPR campaign in the Philippines, and it started still since 2016. There's a nationwide mass CPR Ready Philippines campaign, and we just finished recently last July 17 nationwide mass CPR through online through Facebook. And on my latest reports, we Facebook live uh, Facebook live participants was around 9 to 10,000. So that is really something that really am really encouraging for us to teach everyone on this. It is born out from the what happened to Sambuilim. That's why the Sambuilim bill was passed, which is putting in basic life support training in schools. Hopefully, this will be implemented in the near future. Now, in terms of hands-only CPR, because if for hospital cardiac arrest, this is the minimum that we can do. Before, we teach, you just do the 3 Cs. You check, survey the scene, check responsiveness, and you touch the patient, hey, are you okay? Second is call and call for help, activate EMS, and third is compress. Do high quality chest compressions with the proper depth, push hard and fast, and you don't stop until the EMS arrives, until the patient has signs of life. So this is the usual flow of the hands-only CPR that we teach before. However, due to this time of pandemic, we actually are emphasizing now 5 steps, 5 simple steps in this time of infectious outbreak. So I will go over with the steps. Any patient you witness with a possible cardiac arrest, so patient either collapses, or loses consciousness, or you just see a patient just lying down, not moving, you always consider a patient in cardiac arrest. So what is the first step? The first step is actually to check, like what was previously known. So what do we check? We check for the scene safety, check if the scene is safe, get an idea what happened, and check for responsiveness. So just visually assess without touching the patient. You call the victim's name. Now you check if the victim is not moving and if the victim is not breathing. Now, how will you know if the victim is breathing? If there's chest rise and there's some breathing pattern. Now, if the patient is not moving and is not breathing or with gasping, patient is in cardiac arrest. No need to check for pulse. Just check if the patient is not moving, not breathing, or just gasping, patient is in cardiac arrest. So what is the second step? After knowing the patient is cardiac arrest, you call for help. When I talk about calling for help, as I said earlier, you need to activate the emergency medical system and inform the rescue group that there's a possible COVID infection. So they will be prepared. So you call the local hotline emergency numbers or the nearest rescue group for them to get an AED and bring and apply the AED on these patients because they might need the AED. Okay, so this will be the second step. Third step, so the first is check, second is call, the third step is cover. So this is 5 Cs. Cover, what do you mean by cover? We cover the rescuers, we cover the rescuer and the victim. So we protect the rescuer and we cover the amount of the victim. So how do we do this? So as I said earlier, the rescuer should wear the surgical face mask at the minimum. If you have no PPE, you wear surgical face mask, N94 or N95, and gloves. And if it's available, you wear a PPE. If it's available. If not, just wear the minimum surgical face mask and N95, and just cover the victim's mouth and nose with a surgical mask or a cloth. That would be the third step. Now, fourth step, you now compress, do chest compressions, hands only CPR. So what we emphasize is high quality chest compressions. So what is high quality chest compressions? Keep the elbow straight, compress at the center of the chest, the rate of the 100 to 120 per minute, the right depth, allow chest recoil, and just repeat it every 2 minutes until EMS arrives. So this is the usual thing that we teach. When you start compressions, the shoulders over the hands, elbows locked, arms straight. And when you perform high quality chest compressions, you keep the hand in contact in chest at all times and with the proper depth. You will know this when you practice in a mannequin with the proper rate, 100 to 120 per minute, and you allow complete chest recoil. So that would be your high quality chest compressions. Now, while doing this, when the rescue group arrives, that's the time that you would connect. That's the fifth step. You connect the AED. So in this case, the patient still covered with the mask. And when you connect the AED, you turn on the machine, you attach electrode pads, and just follow the voice prompts. When the machine advises shock, you just press the shock button and do CPR. You repeat the flow every 2 minutes until with signs of life. So this is a mnemonic for using AEDs. First is you power on the machine, activate AED, attach electrode pads, evaluate. The machine will tell you stand clear, will analyze the rhythm for about a few seconds. Then if if the machine says shock advice, you deliver the shock. And after delivering the shock, you resume CPR. So you repeat this process every 2 minutes until patient is revived. And when the patient is revived, you put the patient in a recovery position, still covering the mouth in this recovery position. So as a quick summary, so we did an infographic on the basic 5 C's for out of hospital cardiac arrest for lay people. First step is to check. Second is calling for help, the usual. Then the third is the new one, cover the patient. You protect both the rescuer and the victim by covering using your face mask and cover the patient's mouth. And do high quality chest compressions, compress. And fifth is to connect. And this is what we share now to everyone, this infographic. So as a summary, as I've said, in terms of cardiopulmonary resuscitation, this can be safely done in auto cardiac arrest, provided the rescuers follow standard safety precautions. So I hope everybody will be confident in saving a life, especially we teach the lay people. When we teach them, if they want to help, they should know how to protect themselves. So just doing hands-on CPR is really sufficient in out of hospital cardiac arrest. And when you call for help, you should notify the dispatcher, especially for suspects of COVID-19, for them to prepare. And CPR should be limited only to continuous chest compressions. Don't do mouth-to-mouth ventilation, even with use of a pocket CPR mask. You should never perform this because it will increase the chances for transmission. And just cover the victim's mouth when you do CPR because it is aerosol generating. You do not delay defibrillation. Early use of automated external defibrillation significantly increases the odds of survival and does not increase the risk of COVID-19 transmission. And when you give positive pressure ventilation, it's only might be done in pediatric patients because pediatric patients are the usual cause of cardiac arrest are usually respiratory causes. So these are the only groups of people that most likely would be given airway management, positive pressure BBM ventilation. In case you would use a BBM, you should be equipped with a HEPA filter and with properly placed with a bag bulb interface to prevent transmission. And lastly, we should promote mass community awareness on hands-on CPR campaign because this we think is the solution actually. And even though without COVID, if we increase bystander CPR awareness, actually all chances of survival really increases. And the challenge only now is because of the COVID, we only need to protect ourselves and still maintain that knowledge and awareness that this giving hands-only CPR is sufficient to help and save a life. So with that, I think that's my last slide. And I just want to promote everyone. Hopefully everyone will be CPR ready. And the vision of Philippine Heart Association is by 2021, there will be a CPR ready Philippines. Again, thank you everyone.
Paano lang sir yung sa screen share, sir? Thank you, Dr. Francis, for that thorough discussion. So before we move to the next lecture, just to address certain concerns. So regarding a copy of the slides, so this PCP DOH webinar is being recorded as mentioned. So you can access the full video at the Philippine College of Physicians FB webpage or at YouTube. Regarding the certificate, so we'll be giving a certificate with meriting 1 CPD unit for attending this PCP DOH webinar. Now to move to our next lecture. So a while ago, Dr. Francis Labapi discussed the out-of-hospital cardiac arrest resuscitation in this time of the pandemic, as well as the modification of the CPR protocol. Now let's discuss the in-hospital cardiac arrest resuscitation, again still in this time of pandemic. And our lecturer will be Dr. Neil Wayne C. Salces. Okay, sir, ready?
Good morning.
Good morning, sir.
Did you hear me? Okay. Let me share my slides. Can you now see my slides?
Yes, sir. Ano mo lang,
Okay,
sir.
can I start?
Yes, sir.
Okay. Good morning, everyone. Thank you to the Philippine College of Physicians for inviting us for today's lecture to tackle on cardiopulmonary resuscitation in the time of COVID-19 pandemic. Okay, particularly I'll be tackling on the part of in-hospital cardiac arrest.
Sir, can you put in slideshow?
Oh, wait, sorry. Okay, how about that? Okay. So existing,
I'm sorry, naka-presenter's view siya, sir.
sorry. This is not. Wait a while. How about that?
Still, presenter's view pa rin, sir. So while Dr. Neil Salces is still handling this technical issue, so we would like to say hi to our more than 1,000 attendees. So we have more than 500 in our Zoom, as well as almost 500 in our FB Live. So you're coming from all over the Philippines.
How about that, Greg?
Okay, much better.
Okay, so good morning once again. So existing resuscitation guidelines do not address the challenges of providing resuscitation in the setting of coronavirus disease global pandemic, wherein the rescuer must continuously balance the immediate needs of the patients with their own safety. So healthcare workers are at highest risk since CPR involves performing aerosol generating procedures, as what was mentioned earlier. So the evolving and expanding outbreak of SARS-CoV-2 infection has created important challenges to resuscitation efforts, and this requires modifications of the established processes and practices. So the challenge is to ensure that patients with or without COVID-19 who experience cardiac arrest get the best possible chance of survival without compromising the safety of rescuers who will be needed then to care for future patients. Complicating the emergency response to both out of hospital, as mentioned, as lectured by Dr. Lavapi earlier, and in hospital cardiac arrest is that COVID-19 is highly transmissible, particularly during cardiopulmonary resuscitation, and carries a high morbidity and mortality. Now, why do resuscitations carry added risk to healthcare workers? First, the administration of CPR involves performing numerous aerosol generating procedures, including chest compressions, positive pressure ventilation, and establishment of an advanced airway. During those procedures, viral particles can remain suspended in the air and be inhaled by those nearby. Second, resuscitation efforts require numerous providers to work in close proximity to one another and the patient. And finally, these are high stress emergency events in which the immediate needs of the patient requiring resuscitation may result in lapses in the infection control practices. Okay, so there are general principles for resuscitation of patients with suspected and or confirmed COVID-19 in the hospital setting. So primarily, we want to reduce the provider exposure to COVID-19. We also would like to prioritize oxygenation and ventilation with lower aerosolization risk and consider the appropriateness of starting and continuing um, cardiopulmonary resuscitation. So it is essential that providers protect themselves and their colleagues from unnecessary exposure. Exposed providers who contract COVID-19 further decrease the already strained workforce available to respond and have potential to add additional strain if they have become critically ill. So there are strategies to reduce provider exposure. And Dr. Lavapi already mentioned this. However, it was basically more on the out of hospital cardiac arrest. So for in the hospital, before entering the scene, all rescuers should don on PPE to guard against contact with both airborne and droplet precautions. You have to consult individual health or emergency medical services system standards because PPE recommendations may vary considerably on the basis of the current epidemiological data and availability. You also need to limit personnel in the room or on the scene to only those essential for the patient care. In the settings with protocols in place and expertise in their use, we can consider replacing manual chest compressions with mechanical CPR devices to reduce the number of rescuers required. However, this is probably not available in our local setting. And lastly, we need to clearly communicate COVID-19 status to any new provider before their arrival on the scene or receipt of the patient when transferring to a second setting. So these are the recommendations from the European uh, Resuscitation Council on the minimum droplet precautions PPE. These are your gloves, short sleeve apron, fluid resistant surgical mask, and eye and face protection. There are also minimum airborne precaution PPE, and this includes your gloves, your long sleeve gowns, filtering face piece or an N99 or N95 respirators, an eye and face protection, and the powered air purifying respirators with hood. This can be used as an alternative. However, this is very expensive. No? So these are other PPE recommendation based on the CDC and on the um, National Health Services of Scotland. So another strategy or priority is oxygenation and ventilation strategies. Although the procedure of intubation carries a high risk of aerosolization, if the patient is intubated with a coughed ETT and connected to a ventilator with a high efficiency particulate air or a HEPA filter in the path of exhaled gas and an inline suction catheter, the resulting closed circuit carries a lower risk of aerosolization than any other form of positive pressure ventilation. These are the strategies to lower aerosolization risk. Now, attachment of a HEPA filter securely, if available, to any manual or mechanical ventilation device in the path of exhaled gas before administering any breaths. After a healthcare provider assess the rhythm and defibrillate any ventricular arrhythmias, patients in cardiac arrest should be intubated with a cough tube at the earliest feasible opportunity. You connect the endotracheal tube to a ventilator with a HEPA filter when available. You also minimize the likelihood of failed intubation attempts by the following: assigning to the provider and approach with the best chance of first pass success to intubate, and pausing during chest compressions to intubate. You also need to consider the use of video laryngoscopy if available. So before intubation, use a bag mask device with a HEPA filter and a tight seal, or for adults, consider passive oxygenation with a non-breathing face mask covered by a surgical mask. This was basically a recommendation from both the European Resuscitation Council and American Heart Association. Before intubation, or if intubation is being delayed, you consider manual ventilation with a supraglottic airway or a bag mask device with a HEPA filter. And once already on closed circuit, you minimize disconnection to be able to reduce aerosolization. Now, CPR is a high intensity team effort, and in the context of COVID-19, the risk to the clinical team is increased. Although the outcomes for cardiac arrest in COVID-19 are still unknown, the mortality for critically ill patients with COVID-19 is high and rises with increasing age and comorbidities, particularly cardiovascular disease. Therefore, it is reasonable to consider age, comorbidities, and severity of illness in determining the appropriateness of resuscitation and to balance the likelihood of success against the risk to rescuers and patients from whom resources are being diverted. Now, let's proceed with the algorithms with the specific key changes that is used for this pandemic. Dr. Lavapi already mentioned about the out-of-hospital cardiac arrest. Now let's focus on the algorithm and advanced cardiac life support adult cardiac arrest algorithms for those patients with suspected or confirmed COVID-19. So with an advanced cardiac life support, after ensuring safety by donning on your PPE, you start your CPR and give oxygen to limit aerosolization and immediately prepare the patient for intubation. If the rhythm is shockable, if you have ventricular fibrillation or a pulseless ventricular tachycardia, immediately deliver the shock. And if the rhythm is non-shockable, prioritize intubation and resume CPR. They recommend to pause chest compressions during intubation. If intubation is delayed, consider supraglottic airway or bag mask device with filter and tight seal, and you immediately connect the ventilator with filter when possible. Some considerations in providing an advanced airway are the following. You minimize closed circuit disconnection, use of intubator with the highest likelihood of first pass success, and consideration of using video laryngoscopy. Now, the AHA also recommends to consider mechanical compression devices when available. In our local setting, the Philippine Heart Association Council in Cardiopulmonary Resuscitation also made an interim guidelines on resuscitating patients in the hospital with cardiac arrest. So if a patient is seen unconscious or moving on visual assessment, rescuer safety should be prioritized. So we recommend that the rescuer should don on a PPE. So these are the minimum required based on the recommendations provided by the PHA CPR Council. If the victim is unresponsive, alert the code team of a possible COVID-19 infection. You call for help and check for pulse and breathing. So we discourage listening and feeling for breathing anymore. If there is no pulse and no breathing, you proceed with CPR, and we recommend the following. Avoid rescue breaths, avoid bag mask ventilation. If with advanced airway in place, you do continuous chest compressions, while on mechanical ventilation, maintaining a closed system. If without an advanced airway, you can do hands-only CPR and consider early intubation. The same with the AHA, we recommend that the most experienced person should be the one to manage the airway. If the rhythm is shockable, defibrillation should still be done, and the rest of the algorithm in our cardiac arrest should still be followed. Now, specifically, these are specific provisions in the local guidelines, which include the following. For airway and ventilation, if not on mechanical ventilations, I mentioned this earlier. Another thing is that we recommend a clear aerosol box over the head, if available, and consider early advanced airway. In case of a difficult airway, you can put a surgical mask over the patient's nose and mouth and proceed with hands-only CPR. to prevent aerosolization. If on mechanical ventilation, you do not disconnect the patient from the mechanical ventilator. Now, another provision is that during chest compression, you perform continuous chest compression regardless of the presence or absence of advanced airway. If the patient arrests while in prone position, you turn the patient supine, then proceed with conventional CPR. If ever the patient is in prone position and you need to do compressions, if you have the expertise to do so, then you can proceed with doing prone CPR. You also hook to automatic compression devices if available. However, as mentioned earlier, I don't think we have it here in the country. Now, this is a video that is provided by the one of the hospitals in New York, wherein they tried to do or evaluate the presence of aerosol generating procedure. Sequence 1 is a non-intubated simulated patient, of course, donned on with an NRB, non-rebreathing mask, and a translucent plastic drape prior to starting the ACLS protocol. So examination with the ultraviolet light showed particles that is entirely prominent in the naso and oropharynx. So there are additional particles that is contained within the non-rebreather mask. And there was no contamination that was seen on the providers. Okay, session 2 is the standard, sequence 2 is the standard protocol that is used not in the time of pandemic. They also evaluated the presence of aerosol generation during this procedure if without observing the process that is done in a pandemic. So what they found out is that there were no particles on compressions providers' gown or mask. And however, there are minimal particles on compressions providers' gloves, as well as particles prominent in the naso and oropharynx. There are also particles that were seen on airway providers' gloves, and particles as well on airway providers' gowns. So without practicing or donning on or covering the airway enough, there will be aerosol generation. So sequence 3 is a simulation of patient that is already intubated. So you keep the circuit intact and the rate adjusted on ventilator. So later I'll be showing to you the process on ventilation during a CPR. So what they found out with this sequence is that particles were confined to oropharynx and minimally on the drapes. There were no contamination of providers. And the standard protocol in an intubated patient, we will see how this can generate aerosol, because normally when we intubate, when we have a patient who is coded on mechanical ventilation, we usually detach the mechanical ventilator and do ambu-bagging in this patient. So what are the results when they did this one? Airway provider's gown is contaminated, so there were particles that were seen. And the compression provider's face mask was also contaminated because of the droplets that were generated during the compression. Okay. So there are situation and setting specific consideration during an arrest in the time of pandemic. So intubated patients at the time of cardiac arrest, you consider leaving the patient on a mechanical ventilator with a HEPA filter to maintain a closed circuit and to reduce aerosolization. You also adjust the ventilator settings to allow asynchronous ventilation, and you consider the following suggestions. Do not disconnect the ventilator circuit when starting CPR to avoid aerosol generation. You increase the FiO2 to 100% as what we usually do, and set the ventilator to deliver 10 breaths per minute. It may be necessary to use either pressure or volume control mode and to increase the pressure limits. You also limit pressure or tidal volume to generate an adequate chest rise, and you adjust the trigger to an off mode to prevent the ventilator from auto-triggering with chest compression and possibly prevent hyperventilation and air trapping. Now, COVID-19 patients are often managed in the prone position because this can improve oxygenation. And most of these patients will be intubated, but there are some cases wherein awake, unintubated COVID-19 patients may also be nursed in the prone position. So for patients with suspected or confirmed COVID-19 who are in a prone position without an advanced airway, you attempt to place the patient in a supine position for continued resuscitation. Although the effectiveness of CPR in the prone position is not completely known, for those patients who are in the prone position with an advanced airway, it may be reasonable to avoid turning the patient to the supine position unless you are able to do so without the risk of equipment disconnections as well as aerosolization. It is possible to deliver chest compressions by pressing the patient's back. This can provide some perfusion of vital organs while the team prepares to turn the patient supine. So how do you turn prone patients who are intubated into supine position? Well, of course, the resuscitation members should wear airborne precaution PPE. So they should be donning on their personal protective equipment. You compress between the scapulae at the usual depth and rate with hands in the standard position over the T7 to T10 vertebral bodies. You turn the patient supine if there is already ineffective compressions, if there are interventions requiring the patient to be in supine position, like an airway problem, or you're unable to restore circulation rapidly. If you're unable to safely transition the patient to a supine position and there might be a need to do defibrillation, you can place the defibrillator pads in the anterior posterior position, meaning front and back or biaxillary position. So in summary, it is a challenge to balance the competing interests of providing timely and high quality resuscitation in persons with possible or confirmed COVID-19 and simultaneously protecting the rescuers. CPR interventions, including chest compressions, positive pressure ventilation, and establishment of an advanced airway, are aerosol generating procedures. And these resuscitation efforts carry added risk to healthcare workers. Therefore, during resuscitation, it is vital to reduce provider exposure, lower aerosolization risk, and consider resuscitation appropriateness. Patients with or without COVID-19 who experience cardiac arrest should still get the best possible chance of survival without compromising the safety of rescuer. This ends my slides. Thank you and good morning once again.
Sir, stop sharing. Okay. So thank you, Dr. Salces. So thank you, Dr. Salces, Dr. Francis Labapi, for sharing your expertise today. So we move now to the open forum. Okay. First question. Okay. So this was posted by Satika Jariatam Kiti. So good morning. I would like to ask the question that if CPR is done by bystanders who are not trained, would it cause more severity to the patients? What is better for the untrained bystanders, not to do CPR and wait, or just do the CPR?
Okay, so actually, if we talk about bystander CPR, before these people were actually able to do hands-only CPR in patients, they were at the minimum were aware of what to do. That's why what we want really to encourage everyone is to be aware of what's the simplest way to do. So as I stated a while ago, the simplest way is to know how to recognize an arrest. That's very simple. Just check if it's not breathing and it's not moving. And the only thing that you will do is to call for help, protect yourself, and then just do the simple chest compressions, not giving not giving the ventilations. So the chest compressions are just what we teach in lay people. You just give 100 to 120 just to the tune of staying alive. That would be simple. And if you're the rescuer is of the same size with the victim, you would not really injure the victim. But if the rescuer is larger than the victim, chances for having a rib fracture will be high. So if you're rescuing, if you're doing CPR in a patient that's of the same size, even though you haven't tried yet in a person, the likelihood of having a fracture will be less. So technically speaking, it would be safe if a regular bystander, even not trained, just aware and wants to help with all the precautions that he already knows. And I think he can really save a life. And all things would start from just all things will start from knowing. So that's why even though if the rescuer is untrained, um, if he has the confidence and he's protected, he can really help.
Okay, thank you, sir. Parang ito yata
Yes,
yung
yes.
pinopromote natin na CPR Ready Philippines.
Yeah, yeah.
Okay. So
Yes,
next,
yes.
next question, sir. Actually, it was not posted here. It was from Edward Anthony de Borja. Although I think this is a self-explanatory question. Is there a difference between witness and unwitnessed cardiac arrest with regards to wearing of PPEs?
There's no difference
Okay.
because you can really see patients witness arrest or unwitnessed. You just saw a patient lying down, not moving, so that's unwitnessed. You might see a patient really a witness arrest. There will be no changes in terms of management, in terms of giving resuscitation. Still follow the usual procedure. The only difference is we should protect ourselves by using at the minimum surgical face mask. If you have PPE available, then you can wear your PPE, even though it would take time. But the most important thing is rescuer safety. They say that there is no emergency in a pandemic. You need to protect yourself.
Okay, sir. From Anne Margaret Diaz, just a clarification, Doc. If ever rescue breaths need to be given, we can do that if we have tight seal for the bag valve mask and availability of aerosol box. Otherwise, prepare for impending arrest. Thank you.
In terms
Okay.
of using bag valve mask, most of the time, all bystanders or all lay people don't have that. They don't have that equipment. All of this equipment are available with the with the rescue groups or the emergency medical system once activated. So for regular lay people, the minimum that they can do actually is because everybody now has a face mask, right? So they have already the minimum. But if you have the equipment, then that's good. And if not, then just wait for the rescue groups. If you would hesitate to save a life because you're not prepared, then don't intervene. You only intervene if you are really prepared, you have the equipment on the minimum for a lay. But for those people who have the equipment like a bag mask, as I've said earlier, most of the time, uh, only pediatric patients are the one that will really need ventilations or rescue breathing. because the most common cause of cardiac arrest for pediatric patients is of respiratory causes, asphyxiation and all of those. So that's why if you know what to do, the rescuers know what to do, they can actually use the bag valve mask and with proper HEPA filters and tight seal. So that would be only the consideration for using that. Otherwise, don't give rescue breaths, don't give bag valve mask if there's no need, just do hands only CPR.
Okay, thank you, sir.
If
I
I
think
may
this.
just add,
Yes. Okay, sir.
okay.
Yeah,
In the hospital setting, we all know that the team is already ready. We all have the e-cart, which is complete with the materials that is needed for intubation. And in the emergency setting or in the COVID wards, the most of the people, if not all of them, are already donning on their PPE. So if you are in a negative pressure room, or if the room has a HEPA filter that is placed near the patient's head, you can still, based on the recommendation from the American Heart Association, you can still give rescue breaths. You can do a tight seal for the bag valve mask, and if there is an availability of aerosol box, you can still use it. However, the recommendation based on the Philippine Heart Association is that we foresee that most of the hospitals, no, generally speaking, especially in the provinces, there are no negative pressure rooms. There might be lack of aerosol boxes. That is why we shy away with doing rescue breathing, because if you really want to put a tight seal, you need to at least utilize two rescuers, and that will cost an additional person instead of limiting the personnel during an arrest situation.
Okay, thank you, sir. I think this next question is for Dr. Salces. Is there a need to remove all contraptions, AT tube, etc., after pronouncing a COVID-19 positive patient dead?
Ah, okay, that's not part of the scope, but
That yes. Parang
and what we usually do in the hospital setting, just like the normal people, no? After pronouncing that the patient is dead, we cannot just send the patient with an ET tube in place home, no, or in the morgue. So we still do the routine routine post-mortem care, so much so that the rescuer will still be on full protective equipment. Okay, and you have to dismiss those infected materials safely so as not to cause contamination to other areas.
okay. Next, this question is from Edward Daniel Mortalia. Let's say there's an available PPE. Donning it requires a considerable amount of time, especially for first-time donors and laymen who might find this challenging. Does this weigh more than simply putting a mask and initiating early CPR? I think it was already answered a while ago
yeah,
by
yeah,
Dr. Labo.
yes,
Yes.
yes.
Okay. So this is the time that we say that there's no emergency in a pandemic. So we
Those
have
emergency
to,
pandemic,
yes,
yes,
yeah, we have to make sure that
yes.
the rescuer is safe. Okay. And then this one, I think, for Dr. Lavapi, how can I renew my BLS ACLS expired last year? I think you have to go to your hospital admin and then inquire if they have
Yes,
an ACLS program. Okay.
yes.
Next question. I think this is the same as with the question a while ago. Can you recommend disinfection protocols for rooms, wards, post CPR? I think it's not part of the scope, pero I think it's the same message by Dr. Neil Salses a while ago. Okay. I think this one, sir, is very valid by Miss Mary Diana Cepeda. What if the patient arrested in a standalone hemodialysis center? Because this really happens. Okay.
Who wants to answer? Neil,
Um,
you want to answer?
I
Okay.
Okay.
okay. I think all, if not, I think most, if not all, of the hemodialysis centers, all the personnel there are on protective equipment. So they are making sure that the personnel in the dialysis center are um, protected. No, all dialysis centers, they are required to have ACLS certified personnel, nurses who are in the vicinity. And that means that if they have certified ACLS nurses, that should also tell us that they should also have the kits necessary to revive a patient who goes into a cardiac arrest. So if they happen to go into cardiac arrest in a standalone hemodialysis center, the same protocol should be done. Well, I am sure that most of the dialysis centers are already donning on a minimum protective equipment that is necessary, then they can proceed with resuscitating the patient.
Okay, thank you, sir. Now, okay, I think this is a controversial question from Santa Maria. Please define who are the most experienced doctors who will do intubation procedure, anesthesiologist, IM, etc. Some doctors are just pinpointing people of who will intubate. Thank you. Okay.
Okay. Neil, you want to answer, Neil?
It's
Or
okay, you can go ahead.
me?
Sige doc, I'll just
Okay.
say
You just second the motion. Okay.
yes.
In terms of the most experience, actually, that's the problem. There's no definition for the most experience. What probably would be the right parameter to say if you're most experienced? If you have the you have if already experienced intubating patients, rapid sequence in a fast way in many patients already. It could be an internist, it could be an anesthesiologist, it could be a cardiologist, it could be a pulmonologist. However, some hospitals really would advise, because I think for most of the hospitals, the one that will frequently do intubations are the anesthesiologists. So some hospitals would require anesthesiologists to do the intubation, like in our hospital. The most of the doctors who do intubate are the anesthesiologists rather than the cardiologists or even the pulmonologists. However, some hospitals would require a pulmonologist. So it actually would not depend on what specialty you have. It's more of who are the ones who have the experience on most intubations and has experience on rapid sequence intubation. I don't know, Neil, do you have any answer to that?
Okay, in our hospital, doc, the part of the protocol in answering a code from what we call it here is code orange from a COVID-19 suspect or a COVID confirmed patient is that we immediately refer them to an anesthesiologist. So all intubations in this group of patients are done by anesthesiologists. So they are referred immediately. They do rapid sequence intubation and they make use of the CMAC or video laryngoscopy. In the hospital, in one government hospital that I am affiliated, there are instances where the anesthesiologist cannot um, go to immediately to a code because of other procedures that they are doing. The internal medicine residents, the senior residents, were trained by the anesthesia department to do video laryngoscopy intubation, CMAC intubation. So when it happens that the anesthesiologist cannot um, do it, we allow the residents who were trained to do CMAC intubation to do the or to manage the airway.
Okay, thank you, sir. Okay, for some questions, I'll try to answer it. Pwede yung gamitin ng AED kung expired ang AD pad. So, as much as possible, we have to maintain quality assurance, okay? Next, can we use normal plastics like garbage bag to cover patient's face prior to doing CPR in hospital-based CPR? So, it's more of an improvisation?
Yes, I
Uh,
think you can do that.
Okay. Okay, from John Christopher Pasquin. On family members, is it necessary to do rescue breaths? Are there and significant difference benefit in doing it and not? Thank you.
Okay. In terms of doing rescue breaths, as I have said earlier, if, for example, the one arrested was a family member, and you really know that there's no risk for developing COVID, if the cause is most likely of a respiratory cause, then probably yes. But it's a sudden cardiac arrest. Sudden cardiac arrest, as I've stated earlier, if it's a sudden cardiac arrest, you need an AED. Enhanced only CPR actually could suffice. Um, if you really know the patient, then you can do rescue. If you know what to do, if you know how to do rescue breathing, then yes, you may do. But provided you really are sure. As I've said earlier, if you're not sure, then don't do rescue breathing. Just do hands-on CPR because it will suffice. And just do high quality chest compressions and wait, call for help for the AED to arrive. As I've said earlier also, the most of the time that you use on rescue breathing is for pediatric patients, neonates, less than 1 year old, because most common cause of arrest in these groups of people really of respiratory causes. Just make sure that you know what to do. But if you don't know what to do, then don't do anything. Just do chest compressions.
Okay.
Yeah.
Okay, thank you, sir. I think we
Yes.
really have lots and lots of questions, but we're going to limit it to the last 5 questions. So, okay, patient known chest fracture as much as possible. We don't do that. Okay, paano
Yes.
if mag CPR sa mga pregnant women 5 to 6 months? I think this was if you have guys chance to access the National CPR Day. It was discussed by Dr. Francis Labapi there. Okay, so we just have to put them on the side. Okay. Can a care provider refuse to intubate a COVID-19 patient during in-hospital arrest, especially if the patient is known to have poor chances of survival?
O'Neill.
Okay. So that's a very valid question. No? It requires ethics to be able to do that. If the patient has less poor chance of survival, you can ask the family if the patient has an advanced directives as to do not resuscitate, do not resuscitate, or do not attempt to resuscitate these patients. So, but ideally, if the family is aggressive and they want a chance, as I've mentioned earlier, COVID or non-COVID, they should get the same chance of survival. No, we need to give them the chance of survival by doing your cardiopulmonary resuscitation. um, as healthcare workers, it is unethical to do it, not providing intubation during CP arrest. But in the normal, we all know that in the standard procedure, intubation is not really an immediate thing that should be done based on the algorithm. You can just do valve mask maneuver and then prepare to intubate later on. Now, in terms of this COVID pandemic, we try to intubate as early as possible to avoid aerosolization. So, on that part, if it's really hard for us to say that the patient has poor chances of survival because when the patient arrives at the emergency room, they probably we cannot still get an accurate history and physical examination by then if they already are arrested. So we need to revive them and try to put an advanced airway. But very important thing is there should be someone who can talk to the family members and explain to them, no, especially if the patient is very elderly and there are known comorbidities that would put the patient at more risk of dying, then probably we can discuss that and you know see if we can do away with resuscitation and just let the patient you know
Okay. Next question. I think this is still for Dr. Nalces from Luis Sonny Nimeno Guarin. If during chest compression, the mechanical ventilator circuit accidentally removed, there's a possible aerosolization. What can we do? So I think PPE pa rin. So sir, would you still like to comment?
yes. As shown in the video, if the patient is intubated, there should be someone who should be looking into the connections to make sure that there will be no disconnection during the time that you do the CPR. But if that really happens, accidentally, there was some form of disconnection that happened, then we are not too worried because all the rescuers who are there are already on personal protective equipment. So even if there's aerosolization, then they are still protected. The thing that we should be careful is that during doffing off that should the one who is resuscitating with possible droplets in the PPE that he has should be doffing off very carefully to make sure that there will be no contact with the droplets that is in the personal protective equipment.
Okay. Here's another one. I think it's more of a comment, a suggestion. I think it's high time to require or include first aid and BLS, CPR, AED training in senior high school curriculum at K-12. Your thoughts on this? I think this was already addressed in the Samboy Lim, sir.
Yeah. Yes, sir.
Okay.
With regards to that, we're still on the process of formulating the implementing rules and regulations. It was hampered because of the COVID-19 pandemic. We actually have subsequent meetings to the with the Department of Education. Hopefully, if they will, if will resume the meetings, and DepEd actually will form that curriculum. And the estimate is if you form a curriculum, you would wait around a year because it will be piloted first. But it's already starting. We already am starting on the discussions on the implementing rules and regulations.
Okay. Last three questions. So this one is from Harold Hayes Cortez. Sorry, I was late. I'm not sure if this was discussed previously. Can we limit the duration of resuscitation efforts? If yes, what is the max duration?
Um, Actually, there is no limit. There's no prescribed limit. If it's actually a judgment call of the doctor, of the one who's doing the rescue, because if he really feels that the patient has a high chance of surviving, for example, patients in drowning, patients with electrocution, patients with drug overdose. These are people with the high chance of probable survival with a cardiac arrest. But if it depends on actually what is the condition. Now, with terms of maximum duration, there's really no limit also. But what we do is there's like a cap. What we do usually, if you were sedating a patient and there's still no signs of life by 15 minutes, I would suggest you talk to the relatives, and then you talk about the prognosis, because beyond 15 minutes, really, the chances for survival is really going low, and the chances for brain injury is really high. And so that's why if you put in like a 30-minute limit for that patient, or a 20-minute limit, is really acceptable, because the relatives already knows what is the prognosis. So I think that's one gauge or parameter that you can use in terms of knowing what or how long would you resuscitate a patient.
Okay. Second to the last. So there's a new study. This is from Dr. Antonio Kimbao. There's a new study saying that aerosol boxes may actually do more harm than protect against COVID-19. Will this affect future CPR recommendations, or will there be alternatives to this?
Um, that comment regarding the aerosol boxes, yes, there are some studies that would say that it may cause it will do more harm than good. Probably we will see as to how the recommendations would go about, especially that there are those studies that are coming out already. When we made because the aerosol boxes were recommended by the local guidelines, there was no mention in the HA so much about it in the ERS, but we tried to incorporate it in the local guidelines because most hospitals are doing it for protection of aerosol generation. Now that there are studies already that would tell us that it may do more harm, then probably we can look into the our recommendations and do some revisions, since this is an evolving topic. This is a pandemic, and there are new things that comes out every now and then, so we can always do some revisions with it.
Okay. And then for our last question, I think this is medical legal. So what is the liability of a bystander if he or she conducted CPR to a patient, then it dies? Or the patient, or ginawa ng mga it, and then the patient dies.
Okay, I think that's the what we call the Good Samaritan law. Actually, in the Philippines, there's still no Good Samaritan law, and only in America and other countries. But for us, if you are trained or learned or just being aware of what to do, then I think you're not liable because there's really no law that would that will make you liable. If you are saving a life or your all of your efforts, you give all of your efforts, and the patient dies, at least you did something. No one will be liable if you save a life, unless there's a law. If there's no law yet, you will not be liable for anything. You will not be charged for anything, because if that bystander really was able to train or was able to be aware of how to do CPR, then he or she is not liable. We already asked that question to some of our legal doctors, like Dr. Angie Yap, which is a cardiologist, and also he says that it is really safe because there's still no law. If you just intervene, if you know what to do, that would be the best, I think, way how to approach that.
Okay, thank you. So this was really a very good Monday morning discussion with
Dr.
Dr.
Pang,
Francis. Yes, you want to
excuse
comment?
Yeah.
me. I think there is one more question that is very important from Dr. Roberto Raimundo. Can you?
Roboto. Yeah.
Okay.
Yes, because
Um,
that is one of the concerns of most of the doctors, and I
Yes.
think we should need to know
okay. So
about it.
how does the Council on CPR plan to carry out BLS, ACLS training and
BLS.
certification during these times without the face-to-face training? Yeah.
Okay, so actually, this has been a problem for us from the start of the pandemic because all of the trainings were hampered. And somehow it's an advantage for those people in the hospital, those who are in training, those the doctors, because they already know it just needs recertification. So with that, because of the demand, we're actually we are actually starting already for the online training. Probably, hopefully, we would start and launch it by mid-August. The online training will actually feature on didactic lectures online. Then you will be scheduled for a face-to-face workshop and mega code scheduled. So mostly probably a week after your didactic online lecture, the earliest you will be scheduled for your face to face. So we will launch it probably by August. However, we will try to give this first to those for recertification. For those for new trainees, I think these things will also be applied, but there will be more intensive face-to-face learning facilitator driven teachings with proper donning of PPEs probably, or distancing on the scheduled training. So that would be the setup that we will do. For the people who are for certification, we actually, for hospitals, we're actually extending the validity of the certification by 6 months. That would be December, just for recertification, because probably by that time, hopefully, all this will clear out, and we can actually start the usual trainings with proper distancing, I think.
Okay. In
Okay.
addition,
Yeah, yeah.
we all know that ACLS, BLS certification requires skills. So yes, we provided an online training for the modules, but definitely it cannot be completed without a face-to-face because, as I've said, it requires skills. So we really need to do it after the online modules that's been done, as mentioned by Dr. Lavapi, that a face-to-face training is really recommended or needed before a certificate is being given to a trainee.
Yes, yes.
Okay. So any last reminders to them? Okay. So thank you, Dr. Francis Lavapi and Dr. Neil Wayne Salces for this very energetic Monday morning webinar series. So just to show for our lecture for next week, Okay, so just show you. So for next week, July 27, Monday at 10 a.m., our topic will be COVID-19 prevention in evacuation centers during disasters. Our lecturer will be Dr. Johnny Rivera, is an infectious disease specialist, and our moderator will be Dr. Rosel Jade Javier. Okay. And just to take this opportunity, so from the Philippine Society of Vascular Medicine, we celebrate every year a PAD Awareness Day. So this year it is slated on July 26. So the topic is going to be mobile lecture, Road to Wellness, the 14th annual PAD Awareness Day. So you can just check the Facebook page of PAD Awareness for this. With that, I would like to thank everyone for attending. So we have a number more than 1,000 plus. So we have attendees from as far as Abra and then as south as Zamboanga. We also have someone from a cruise ship. So I think this is a very healthy and very good webinar series today. So keep safe, everyone. Okay. Good luck to us. Thank you.
Thank you.
Thank you. Thank you. Thank you, Neil.
Thank you,
Thanks,
Doc.
sir.